everyone. It's so great to see you all, albeit virtually, at this third DADA2 meeting. And I'm really excited to be back talking with you today about the efficacy of the TNF inhibitors in the treatment of DADA2. And I'm going to toss a couple other little pearls in there that hopefully will cause us to have some more thoughts that we can bring forward into the next meeting. So let's get started. First, I want to give a little background as to why we are doing this and how it came to be. So let's just do this quickly. Back in 2002 and 2011, there were two initial patients with similar clinical features of strokes and inflammatory disease who were seen in the NIH Autoinflammatory Disease Clinic. They were selected as some of our first candidates for exome sequencing. And back in November 2012, we found out that they both had mutations identified in the ADA2 gene. And once we found this, we were able to go through our cohort of patients and identify another 3 patients who also had mutations in ADA2. And so we went about trying to characterize this new disease, which was to be known as DADA2. And one of the things we did in these initial patients is we did skin biopsies trying to figure out what was going on. And you can see these here. In the bottom 2 panels, you have the controls where you just see the nuclei staining blue. But when we stained for TNF alpha, you can see that perivascularly, all of these patients had this red staining, which was showing that there was TNF alpha present. And so knowing that, and then also after we had a failed fresh frozen plasma trial where we tried to use FFP as a vehicle to increase the ADA2 levels, we looked through all of these patients' medication lists, and we saw that not one of them had seen an anti-TNF agent. And that on all the other medications they'd been tried on, they had been having recurrent strokes and breakthrough inflammation and rashes. So knowing what we saw in the skin biopsy, and then also after we talked to our colleagues in Israel who happened to have DADA2 patients as well, we heard from them that they had had a couple who had been just tried on anti-TNF agents and had a pretty good response. So in June 2013, we initiated in 3 of our DADA2 patients etanercept. And then in February 2014, we had the initial publication in the New England Journal, which described DADA2. And with this publication came a lot more referrals to the clinic. So by September 2014, there were 11 patients on treatment. And what we started hearing from these families was that the patients had a lot more energy. They were a lot less fatigued. Their fevers were gone. The rashes weren't coming like they used to. And they were very pleased. And then serologically, we noted that the inflammatory burden as measured by their acute phase reactants had been reduced significantly. And that their hematologic parameters were showing that their anemia of inflammatory disease was slowly correcting. And so right there, we had some good evidence that we were on the right track with something. And then as time went by, we slowly started offering the medication to all of our patients. And so as of November 2020, as of today, we have 48 of our 57 patients currently on anti-TNF therapy. There are 6 patients who have undergone stem cell transplant successfully and are no longer on it, and 3 patients who declined the offer of the medication. Now, I told you what we initially saw clinically, but then as time went on, it slowly dawned on us that these patients who had been in our cohort, and while they were in our cohort prior to anti-TNF treatment, were having recurrent strokes, that we weren't getting those calls in the middle of the night saying, I have your patient here, they've had a stroke, they're in the hospital. And so we looked and we started to look at it statistically. And what we saw was that in the 2,077 patient months prior to anti-TNF initiation, there had been 55 strokes, but that in the 733 accumulated patient months post anti-TNF initiation, there were none. And so this was such an amazing moment when we discovered this, that we were, again, lucky enough to have this published as a follow-up in the New England Journal of Medicine in April 2019. And that was in 15 patients. Ryan Laird has gone through our patient cohort now of 58 and selected out the 24 patients who had a history of stroke. And he has plotted them on this nice chart, which you can see here. Each horizontal line represents one of our patients. Each black circle represents a stroke. The red and yellow portions of the bar are the time prior to anti-TNF initiation, and then the aqua color is the time after anti-TNF agents were initiated. So in that pre-treatment phase, throughout these 24 patients, we had had a history of 78 total strokes. And then in the aqua or blue period after initiation of TNF treatment, there have been none. So what you can see is that these patients used to have clusters of strokes, or they would be spaced out throughout time. But over time, as the word of DATA2 is getting out and people are getting better at recognizing it, you can see that the time to anti-TNF initiation is occurring much younger in one's lifespan, and that also you're not seeing all of these repeated strokes occurring anymore. So we're getting better. We're picking up on this disease faster, and these patients are benefiting from the definite stroke reduction they have. So now we've talked about the clinical improvement. We talked a little bit about the serologic improvement and also the stroke risk reduction in DATA2 patients. But then we wanted to say what's going on immunologically. And remember a few slides ago, I showed you those pre-anti-TNF skin biopsies that we had done in all the patients. Well, we decided to bring those patients back and do a post-anti-TNF skin biopsy to see what we would see. And here are the results of that. In the top row, we see all of the pre-anti-TNF biopsies lined in a row here. And as you can see again, that in each of them, aside from the control, which is here in the first column, you can see each of them have the red indicative of the TNF alpha being present. But then in these follow-up post-anti-TNF biopsies, you can see down here, there's no more red. We have effectively removed the TNF alpha from being present perivascularly. So now let's talk a little bit more about what else the anti-TNF agents have done and what they have failed to do in DATA2. So from a growth and development standpoint, when these patients initially came to us, they were quite inflamed, and a lot of them had a lot of growth retardation. As you can see in this 7.5-year-old little girl, she had a height of less than 3rd percentile when she first started on anti-TNF treatment. You can also see that she has Cushingoid facies as she was on a prednisone dose of 0.4 milligrams per kilogram per day, and also that she had a very protuberant belly and a dilated superficial vessel here. She also had prominent livido-racemosa. 3.5 years after initiating anti-TNF treatment, you can see that her height had increased to 25th to 50th percentile. Her prednisone dose had been reduced to nothing, and you can see that her abdomen does not appear quite so protuberant. And then let's fast forward another 2.5 years to where she had continued to grow and was now at the 50th percentile. She had entered puberty. Her prednisone dose when she came to see us on this day was actually 0.67 mg per kg per day because she had had an optic neuritis scare that we were treating her with a tapered course. She was effectively managed to be tapered back off on her prednisone and has remained off for over a year, and she continues to grow and develop nicely. Now let's talk a little more about that protuberant abdomen. When we initially evaluated her, we found that she had portal hypertension with esophageal varices, as well as that dilated vessel on the superficial part of her abdomen. And we found that she had marked splenomegaly of 16 centimeters on ultrasound. 3.5 years after the anti-TNF was started, you can see that her spleen size had reduced, but that also with the marked amount of growth that she had had, her protuberant belly was less. And then on the most recent one from last year, you can see that her spleen had further reduction in size, and actually now it had entered the normal size range. Her liver was also in a normal size range, and hepatology saw her, evaluated her, and declared her to be free from her portal hypertension. So in each of our patients that comes to the NIH, we like to perform transient elastography or fibroscans on the patients to measure their liver stiffness. A normal value for a healthy liver would be below 7. But as you can see in the patients, when they initially presented to us pre-anti-TNF treatment, a lot of them were above that 7 cutoff. But that with treatment, they have all come down into a normal level. There are a couple outliers here, one of them being a little boy who was requiring a lot of blood transfusions, who got some iron overload to his liver. And then another older gentleman who has some steatosis that is accumulated that is altering the stiffness of his liver as well. But far and beyond, we've seen vast improvements in their transient elastography. Serologically, you can also see here that once we initiated treatment with the anti-TNFs, their acute phase reactants and inflammatory burden were effectively decreased. And then also, you can see that there was hematologically a gradual increase in their hemoglobin hematocrit and a decrease in their white blood cell counts. Now, that being said, again, there are a couple outliers here. First, we have a little boy who had pure red cell aplasia, who despite having his inflammatory disease well controlled, did not have any response to the anti-TNF in his hemoglobin. And then there was also another little boy who had come to us quite inflamed and with a lot of strokes in his history, who, despite having great control of his inflammatory component of disease, he slowly went on to develop trilineage bone marrow failure. Both of these patients required stem cell transplants and now are doing quite well. So the livedo racemosa, we have a patient who has been on anti-TNF agents for 7 years now in our cohort. And you can see over the course of those 7 years that a series of pictures taken reveals that the livedo never completely goes away. The families do feel that subjectively the patients are doing better and it's not quite so pronounced, but one can fully appreciate that it is still there. So the anti-TNF agents do not rid these patients of their livedo racemosa. And also in regards to the peripheral vascular disease, this is a 30-year-old patient who had presented to us for the first time, and he already had very pronounced Raynaud's. And we had performed a angiogram on him and found that he did have very, very diseased vessels going to the periphery. We initiated him on anti-TNF treatment and we escalated therapy and changed drugs trying to maximize benefit to him. But over the course of 14 months and then 2 years, he went on to develop slow deterioration in his peripheral vascular disease, which now has resulted in him having 2 toes and 2 partial finger amputations. So for him, anti-TNFs weren't enough to bring him back from his peripheral vascular disease. But he is the only person in our cohort who has had this sort of trajectory. The other patients who we have observed with this have been maintained on their anti-TNF and have not progressed in this fashion. So we are still hopeful that although it may not be able to completely correct the peripheral vascular disease, that the anti-TNF agents may offer some sort of blunting of the effect. So I've talked to you about how good the anti-TNFs are in controlling the inflammatory symptoms, but not always so good in the hematologic symptoms and also in the peripheral vascular disease. So how do we treat these complex data 2 patients? And what I mean by complex is I'm going to highlight 3 areas. One, there are the patients who have breakthrough inflammatory periods that come and go. 2, there are patients who are overall doing quite well on their anti-TNFs, but maybe do have this peripheral vascular disease or some other sort that's not necessarily driving them into transplant at the moment, but could use optimization. And then there are those patients who maybe do have trilineage marrow disease where they really could benefit from a transplant, but they have liver disease from their DATA2 that would probably not be able to hold up under the conditioning regimens, or they've had a stroke that left them with impulse control issues that may cause them to have a fit of rage and bang their head into a wall, which again would not be good for a transplant patient. Or some of them have very poor psychosocial living situations where they're in a group home. And again, it might be hard for them to have the support they needed to go through a transplant. So what do we do for these patients? Well, regarding the breakthrough inflammation, the first thing we look at is what anti-TNF agent are they on? We tend to start most of our patients on etanercept when they're very young because it's very easy to dose in a pediatric population. But we have found that there can be breakthrough inflammatory periods on etanercept that can be better controlled by switching them to a monoclonal antibody. But then we also see with the monoclonal antibodies that at times they will have breakthrough periods. And one of the things we've observed in some of our patients is that they have developed anti-drug antibodies. So we have started implementing methotrexate use in addition to the monoclonal antibodies to try and ward off this development. But then there are still some patients who do have breakthrough periods despite our trying to optimize their anti-TNF. And for them, we have used in a few the anti-IL-1 agents. And you may ask, why have you done this? Well, the rationale for this stems from Dr. Carmelo Carmona Rivera's work. And what he did and published in Blood last year is he took DATA2 patient blood and used their low density granulocytes and tested them and found that they produced a lot of spontaneous nets. And what these neutrophilic nets did then was interact with the inflammatory macrophages, which would cause the localization of NF-kappa B to the nucleus, which would set off a pro-inflammatory storm with TNF alpha being released in addition to IL-6 and others. But then when he used anakinra in his experiments, sometimes he would find that that was not able to happen, that the translocation of the NF-kappa B to the nucleus didn't happen. Therefore, the cytokine release didn't happen and patients could have a better outcome, or the cells would have a better outcome. So we used this information based on his work and used anakinra in some of our patients. And those who had documentable inflammation responded very nicely to the anakinra in most cases. But those who didn't were the ones who had neutropenia, other forms of the marrow dysfunction, and the vasculopathy. It didn't really help with them. So these neutropenic patients have been a thorn in our side because we haven't been able to control them with the anti-TNF agents, and also the anakinra addition wasn't helping. So what we did with this and what we are continuing to do is, this is a bone marrow of a 16-year-old boy who came to us. And he had a history of having his absolute neutrophil count go to 0. And he came to us for a transplant evaluation in a first visit, at which time he was on adalimumab. And on his bone marrow biopsy that we did, we found him to be a very hypercellular or inflammatory model. And when we stained with MPO for the myeloid cells, we found that they were there, but they were arrested in their development. All we would find were up to the promyelocytes, and we wouldn't find any more development. And so it appeared as if they were kind of under an attack because they were there. They weren't being not made. But then when we looked at the CD3 stain for the T cells, we found that there was just a swarm of T cells in there with these very immature myeloid cells. And they're not supposed to be there. And these have been described in other case series from around the world of DATA2 patients. So we started thinking, could these T cells be causing this attack on these developing myeloid cells? And can we change this by using a T cell directed therapy in these neutropenic patients? So we discussed using some of these therapies such as cyclosporin, high or low dose glucocorticoids, ATG, and alemtuzumab as potential bridges to transplant, or maybe treatment for those patients who aren't going to be able to go for transplant for one reason or another. And in this boy whose marrow we just saw, when he initially came to us, you can see with this arrow here that he had an ANC of less than 500. But when we put him on cyclosporin 200 milligrams a day, prednisone 10 milligrams a day, in addition to the adalimumab he was taking every other week, and sent him back home because he had about 6 months to wait for his transplant, we found that his ANC rose rather nicely and remained in the normal range until he came back to see us for transplant. He was still in the normal range, and it was only once he entered the conditioning regimen that it dropped again. And we repeated a bone marrow biopsy on him when he came back for transplant, and it showed that those lymphocytes weren't there like they were. And it showed that he had neutrophils. So I've taken this knowledge and interact with some of you from around the world, cautiously making a recommendation that perhaps this might be worth investigating in the neutropenic patients. And I know that in my discussion with Dr. Helen Levis, at least from the Netherlands, that she did have a patient who did also respond to this. So I'm hopeful that maybe if we continue to mold this, that we will find that the T-cell directed therapy might be an adjunct to the anti-TNF in these patients with neutropenia. And then this is exciting. Recently, doctors Rachel Sparks and John Sang undertook an immunologic deep dive of 17 autoinflammatory and immunodeficiency conditions that were evaluated, and they compared them to healthy controls. And one very exciting thing they discovered was that the IL-23 levels were quite high in the DATA2 patients compared to patients who had familial cold autoinflammatory syndrome, familial Mediterranean fever, GATA2, STAT1 gain of function mutations, and healthy individuals. And that the DATA2 patients were the only ones in the study that had higher serum IL-23 concentrations compared to the healthy individuals. So with this piece of information, we said, well, can we look at them and take this information and go back and clinically look at what these patients have? And is there any way of stratifying this? And indeed, it does appear like there is. When we looked at the DATA2 patients, of course, the IL-23 was high overall, but what we found is those who had more severe disease, meaning severe vascular disease, thrombocytopenia, leukopenia and thrombocytopenia, and trilineage marrow failure, had the highest IL-23s of them all. Now, this is very interesting considering that all of them were on anti-TNF agents and their acute phase reactants were well controlled. So we believed that we were adequately treating their inflammatory disease, but yet here we find that we have an inflammatory cytokine that may be indicating that we are not. And so we also discovered that this high IL-23 correlated with the serum interferon gamma levels in these patients. And so this gives us, some more areas to look into, considering whether or not we might want to use an agent like ustekinumab to try to see if we can get better response in some of these patients. So let's just do a quick summary of the anti-TNF effects. We have seen that there have been clear benefits in the ischemic stroke risk, the inflammatory burden, the rashes, and transient elastography. There can be little to no effect that we've seen so far in the red cell aplasia, the peripheral vasculopathy, and the trilineage marrow failure. And that there can be variable, although a lot of times very good response with the hepatomegaly, splenomegaly, but much less predictable with the neutropenia and the immune deficiency. And thanks to Pui Li, who earlier this year released the first genotype-phenotype driven paper that started to show us that those patients who have deletions and frameshift mutations have virtually undetectable enzyme activity. But those who have more of the inflammatory disease and the vasculitis and the missense mutations actually had a little bit, albeit very low, residual ADA activity. So what this goes to show us, and this was in the editorial that we wrote in response to his paper, is that how the ADA2 is governing all these pathways, either enzymatically dependent versus the black box of the enzymatically independent functions, is still so unknown to us. And that there's still so much more that we need to do, because with knowledge comes power. And with power comes the ability for us to be better clinicians and scientists for these patients. So I hope I've given you a good backstory for the utilization of anti-TNF agents, and I hope I've given you some information to think about as we go forward in the next 2 years till the next meeting, that we can use and maybe continue to come up with other therapeutic developments for these patients, and especially those patients who aren't going to be transplant candidates maybe ever. Once again, it's so great to get to see you all. I can't wait to do it next time and sit down and toast our successes. So enjoy the rest of the meeting. And I couldn't do this without my team. There they all are. And it's taken a large number of people, a lot of hours to work together with these patients to discover what we have so far. So let's keep going. Thank you.